All right, why don't we get started? Please stop me if you want to chat about anything. I'm going to try to keep an eye on the chat box, but if I get carried away, just stop me. We'll talk about something. So I'm going to piggyback on Elaine's talk from Monday and talk about more advanced ventilator stuff. But Faraz asked me to do a little bit of a recap and talk some about sedation. So just to recap, if you do assist control and limit your plateau pressures, that will get you most of the way. We prefer assist control over SIMV, and I think by the end of this talk, it will be fairly apparent as to why we have that preference. Induction medications, it really doesn't matter which sedative you use. We like etomidate, ketamine's fine, propofol's fine if you are okay with a hypotensive response and are prepared for it. In terms of the neuromuscular blockers that you use, you need to use a high enough dose of either of them to make sure that they are fully apneic and paralyzed and won't cough. So for rock, we notoriously underdose rocuronium. We just get away with it because we use VL so commonly, but the dose of rocuronium is above 1.2 per kilo. And succinylcholine is 2 milligrams per kilogram. For post-intubation sedation, this could become a problem for us, but in the absence of a problem, fentanyl is our preferred analgesic. And then for sedative, propofol, Dex are fine. A lot of these patients come in with hypertriglyceridemia, so Dex may be an option or the better option. If you're going to paralyze them, which many of these people will be paralyzed, then midazolam is the better option. If you can get away without a continuous infusion of a sedative, then Versed boluses are great. And then we plan on using some sedative sparing maneuvers, like giving people a dusting of phenobarb, Valium, ketamine, so on and so forth, to try to reduce the amount of sedatives that we use to prolong them. And then neuromuscular blockers, we prefer Nimbex because it's not metabolized by the liver or the kidney. It's metabolized by Hoffman degradation, and so it doesn't build up in either renal or liver failure. Atracurium is a cheaper version of that Yvonne tells me they're going to try to stock up on. And then if you just need to go to MRI or CT or something and you want to paralyze them for that, then just give them a dose of vecuronium. Okay, by the end of this talk, hopefully you'll have a better understanding as to why BiPAP's a bad idea in these patients, why high flow may be okay, but we're not sure yet, why it's important to prone the patients, spontaneous breathing's bad, cohorting patients on a single ventilator is terrible, and ECMO will not be our savior.